back to our days at Stony Brook, where we spent many nights in the pediatric ED working together. Dr. Despina did her pediatric residency at Stony Brook University Children's Hospital in Long Island. She then went to Albert Einstein Montefiore, where she was a pediatric critical care fellow. And after graduation, came here to the Mount Sinai Hospital, Travis Children's Hospital. Dr. Despina is currently the fellowship director of the pediatric fellowship, and works in both the pediatric ICU and the cardiac pediatric ICU. Today for Grand Rounds, thank you so much for agreeing to do this.
Thank you so much for inviting me. It's a pleasure. I'm just going to share my screen. Okay, so today I'll be talking about competency in graduate medical education. I do not have any disclosures. And the objectives of the talk today will be to identify the core competencies that are used in graduate medical education, to describe entrustable professional activities, also known as EPAs, and to implement the EPAs in the assessment and entrustment decisions. And so as program director of the PICU Fellowship, I really have become interested in how we can foster, assess, and determine competency in graduate medical education. And so if we think about the vision statement that ACGME has put forth, they envision an environment in which the quadruple aim has been realized. And so this involves competency-based training that has customized professional development and identity formation for all physicians. That this environment is led by inspirational faculty role models that are overseeing supervised humanistic clinical education experiences. And that it is immersed in evidence-based, data-driven clinical learning and care environments, and that these are defined by excellence in clinical care, safety, cost-effectiveness, professionalism, as well as diversity, equity, and inclusion. And that training is located in healthcare delivery systems that are equitably meeting local and regional community needs. And that graduating residents and fellows strive for continuous mastery and altruistic professionalism throughout their careers, placing the needs of their patients and their communities first. So this quadruple aim simultaneously improves the patient experience of care, population health, and healthcare provider work life while lowering per capita cost. And really the goal is for graduates to be able to practice in their chosen field independently, having received the best education possible. And so for this talk, we're going to be focusing on competency-based education. So what are the competencies? For many of you that have been involved in competency committees and graduate medical education a little bit more formally are probably very familiar with this. But we'll kind of go through competency-based medical education as it really is a shift from traditional apprenticeship model to more outcomes-based training, with the ultimate goal that trainees develop and demonstrate the necessary competencies for patient care. And so with competency-based medical education, there's opportunities for all learners to go beyond basic medical knowledge and clinical skills and really emphasizes competencies in the core activities of their discipline. So the competencies provide a conceptual framework that describe the required domains for a trusted physician to enter autonomous practice. And so these competencies are the core to the practice of all physicians, and each subspecialty further defines the specifics of their subspecialty. There's developmental trajectories for each of the competencies, and these are articulated through milestones for each subspecialty, and we'll go through that a little bit more in a bit. So really the focus in fellowship is on subspecialty specific patient care and medical knowledge and refining the other competencies that they've acquired during residency. So as far as the core competencies, there are 6, and this will likely look quite familiar to anyone that's completed evaluations and new innovations. But the 6 core competencies include medical knowledge, patient care, practice-based learning and improvement, interpersonal and communication skills, professionalism, and systems-based practice. So as far as medical knowledge, trainees really must demonstrate knowledge of established and evolving biomedical, clinical, epidemiological, and social behavioral sciences. And they need to be able to apply this knowledge to patient care. And when we think about patient care, this also applies to procedural skills as well, depending on the subspecialty. But really, the goal is for quality patient care to be safe, effective, timely, efficient, patient-centered, equitable, and designed to improve population health while reducing per capita costs. So fellows must be able to provide patient care that's compassionate, appropriate, and effective for the treatment of the health problems that they're treating and the promotion of health. And they must be able to perform all medical, diagnostic, and surgical procedures that are considered essential in their area of practice. As far as practice-based learning and improvement, trainees must demonstrate the ability to investigate and evaluate their care of patients, to appraise and assimilate scientific evidence, and continuously improve patient care based on constant self-evaluation and lifelong learning. So the intention is really to help trainees refine the habits of mind that they need to continuously pursue quality improvement even after they've finished fellowship. And so this core competency of practice-based learning and improvement is really best learned in an environment that gives fellows and residents enough information to investigate and evaluate the care of their patients. So you need to be in an environment that supports open and honest attempts to improve and not punish errors or mistakes as a personal weakness. And so trainees really, in order to identify their strengths, deficiencies, and limitations, need to learn to self-reflect on the care they're providing and try to answer the question of how they can improve the care for their patients. As far as interpersonal and communication skills, fellows must demonstrate the interpersonal communication skills such that they are able to provide an effective exchange of information and collaboration. And that's with patients, their families, as well as other health professionals. And good communication skills, as we all know, improve patient satisfaction and treatment adherence, and can also reduce medication errors. So as a result, efforts to teach communication skills in medical school, residency, and fellowship programs really have significantly increased. Some techniques that have been used to teach these skills include role play, standardized patients, simulation, and real-life experiences such as discussions during morbidity and mortality reviews. And many efforts in teaching communication skills have been successful, but success in this domain also really depends on human variables. And so the ability to effectively communicate does depend on a lot of human factors, which include the individual's own characteristics, including their socio-demographic, professional and personal experiences, health, burnout, depersonalization, their ability to cope, their psychological characteristics, and technological demands. There are also contextual characteristics that contribute to any individual's communication skills, and those include the professional and personal environments. And even communication skills that people have acquired before training also contribute to this. And professionalism as a core competency includes a lot of characteristics that may overlap with some of the other competencies. And so honesty, integrity, reliability and responsibility, respecting others, compassion, empathy, self-improvement, self-awareness and knowledge of limits, communication, collaboration, as well as altruism and advocacy. And honestly, professionalism probably could take up at least an hour in and of itself, but we won't delve there. And as far as the sixth core competency, systems-based practice. So as we all know, we're quite dependent on the healthcare system that we work in order to support our patients. And we need to be able to use that system optimally to benefit our patients. At the same time, we do have the ability to influence the system that we work in order to ensure appropriate support for our patients and their families. So during training, a lot of residents and fellows might work passively in these settings, but the curriculum really must provide the education so that they can actively and positively impact the system in their future practice. So trainees must really demonstrate an awareness of and responsiveness to the larger context and the system of healthcare. And that includes social determinants of health, as well as the ability to call on other resources, again, to provide optimal healthcare. So the question that trainees should ask themselves is how they can help improve the system of care. And they can do this by participating in subspecialty specific didactics or discussions about the practice environment, as well as institution-wide multi-specialty and multidisciplinary discussions. Trainees do have many opportunities to join institutional and program committees that look at the system. So each of these competencies have developmental trajectories, and these are articulated through the milestones for each subspecialty. And it's important to remember that a milestone is really just a significant point in development. And so the milestones in graduate medical education provide narrative descriptions of the core competencies and subcompetencies along a developmental continuum. So they describe the performance levels that trainees are expected to demonstrate for the skills, knowledge, and behaviors in the 6 core competencies for their subspecialty. So here we have an example of a milestone. And again, I'm sure anybody that's completed an evaluation is quite familiar with this, but here we have a milestone that lays out the framework of observable behaviors and other attributes associated with the trainee's development. So this milestone describes the learning trajectory within a subcompetency where you have a learner at the beginning of their subspecialty, which would be a level 1, all the way to a highly proficient fellow or even an early practitioner, which would be a level 5. And milestones are helpful because they can allow a shared understanding of the expectations for the learner. And again, the milestones can provide a framework really even for all graduate medical education programs. Again, it's important to remember that the milestones don't describe or represent a complete description of a clinical discipline. It's really the core of that discipline, but programs really need to use their judgment to fill in the gaps in the curriculum and assessment of the milestones. And the milestones themselves, again, are not the curriculum, but can help guide an analysis of the curriculum so that you can find strengths and gaps in your training programs. The milestones are intended really for formative purposes to help learners, the programs, and review committees so that we can improve the processes for education, assessment, and accreditation. So how can milestones be helpful for trainees? Again, they can provide a descriptive roadmap for education. It really allows for transparency of the performance requirements and encourages informed self-assessment and self-directed learning for trainees, and can facilitate better feedback to the learner, as well as encouraging self-directed feedback-seeking behaviors. How can we use milestones for programs themselves? As I alluded to before, they can help guide curriculum and assessment tool development and really provide a meaningful framework for clinical competency committees. So I'll talk about this in a little bit more detail later, but it allows for the committee to create a shared mental model, provides more explicit expectations of residents and fellows, and supports better systems of assessments and enhanced opportunities to identify underperformers early. In addition to programs using the milestones, ACGME also uses the milestones for accreditation, so they can continuously monitor programs, and they can do that even in between site visits. The milestones do get reported at an aggregated national level on competency outcomes, and again, allows a focus on continuous improvement. Some important notes regarding milestones. So the milestones get reported to ACGME twice a year. They weren't really designed to be used as evaluation forms for specific rotations or experiences, especially if it's a short rotation, less than 3 months. I think, again, we've all had experience completing evaluations that have, the long list of milestones that you need to grade, but the intention really was not for every evaluation to include the milestones. The reporting milestones really, again, were supposed to be a guide so that you can form a synthetic judgment of progress twice a year. You can use the language from the milestones as part of a mapping exercise to determine which competencies are best covered in certain rotations and curricular experiences. Another important note regarding milestones is that they can be used for guided self-assessment and reflection by a trainee in preparation for a feedback session. And they can also be helpful for trainees to create their own individualized learning plans. So they can use the milestones to assess themselves with input and feedback from their faculty advisors, from their mentors, and from the program director. The fellows really shouldn't judge themselves based on their milestones in isolation. But the milestone feedback really is most effective if it's a dialogue between the learner and their faculty advisor. We can also use milestones in faculty development. And so it can help faculty members recognize their performance expectations of learners and more explicitly assess the trajectory of the skill progression in their specialty and discern how best to assess the learner's performance. And again, it's important to remember that the milestones don't include the broader curriculum. And so limiting assessments to the milestones alone could leave a lot of topics without the proper assessment and evaluation, and can leave really important topics uncovered throughout the training program. Now, how does this framework lead to autonomy and entrustment? So we apply the competencies through the definition of entrustable professional activities, or EPAs. And so the EPAs are specialty-specific tasks that the trainee may perform independently once the competence has been demonstrated to their supervisor. So each EPA itself includes several milestones, and those represent the measurable and developmental indicators of the trainee's ability to perform the task. And you can document the progress on milestones and EPAs, and that really requires a shift from a global evaluation of performance on a clinical rotation and summative examinations to workplace-based assessments in the clinical environment. So when we think about the EPAs for pediatric critical care fellows themselves, there are 3 EPAs: the acute management of the critically ill patient, including those with underlying chronic disease; managing and coordinating care in pediatric critical care units for optimal patient outcomes; and management of patients at the end of life. And so it seems pretty simple. These 3 bullet points are pretty much what you have to accomplish in your pediatric critical care fellowship, but of course it's not that simple and straightforward. And each of these EPAs actually includes a 1 to 2 page, well-elaborated description of what these include. So as an example, the acute management of the critically ill patient, really trainees need to be able to identify key issues for care of critically ill patients and forming provisional differential diagnoses. They also need to rapidly develop management plans to address all comorbidities that require attention during a hospitalization and case management issues that may become issues during the hospitalization as well as after the hospitalization. Performing the common procedures needed to care for the patient, including identifying the need for that procedure, and demonstrating the ability to utilize technology, understanding various monitoring techniques and devices, evaluating new technology and adopting it in a fiscally responsible manner, and applying technology to care by integrating it into practice in a way that provides optimal patient outcomes. They also must address and document the primary problem, admission and discharge criteria. And when we think about managing and coordinating care in the PICU for optimal patient outcomes, this includes prioritizing and arranging patient flow in the PICU, which we've been doing a lot of, especially with this recent respiratory surge. Identifying and allocating resources within the PICU based on acuity and patient need. And integrating the input from other members of the healthcare team and reconciling when they have disparate opinions regarding the best course of action. This also includes determining optimal staffing needs to assure appropriate patient care and educating the PICU staff about the treatment of critically ill children and supporting them in their care delivery. And the management of patients at the end of life, of course, this involves leading end-of-life discussions with families and patients in a culturally appropriate manner. It also includes managing goals of care, including pain and suffering at the end of life, coordinating this care with palliative care teams to support the child, their family, and also staff at the end of life. It also includes demonstrating expertise in the brain death exam and communicating those results to families and other healthcare professionals, documenting decisions about end-of-life care in the medical record, and collaborating with organ procurement agencies and authorities to facilitate the management of patients who do become donors. So when we think about entrustment and supervision scales, there basically is a spectrum in which trainees are allowed entrustment and gradually have reduced supervision. And so on one end is that trainees are not allowed to practice a specific EPA, and that may be because they don't have adequate knowledge or skill, and they're not even allowed to observe the EPA. They may not be allowed to practice it even though they have adequate knowledge and skill, but they just are allowed to observe. Next along that spectrum is that they're allowed to practice it, but only with full proactive supervision. And that can be considered as a co-activity with their supervisor, or their supervisor is in the room and ready to step in. And then next along that spectrum is that they're allowed to practice the EPA, but only with reactive or on-demand supervision. And so the supervisor in these cases will be immediately available, double checking all findings and decisions. And they may also be immediately available, but only checking key findings, or they might be distantly available, such as by phone, and they're promptly reviewing findings and decision-making. After that, there's trainees that are allowed to practice a specific EPA without supervision. And so that's either with remote monitoring, so they may check in the next day, or without monitoring at all. And then the full autonomy beyond that would be actually supervising others in the practice of that specific EPA. And so clinical competency committees can use the EPAs, and it really allows for the most effective use of competency-based assessments. And so the committee can make an entrustment determination as a group and then share that information with the larger group of supervisors. And this is really helpful, especially depending how large the faculty group is. The larger it is, the less interactions specific faculty members may have with specific trainees. And so they may not be able to rely on their own experiences with that trainee to determine entrustment. And so for each specific EPA, the group determines competence and then shares that with the larger group. We all have had experiences with faculty members that even if you tell them that a specific trainee has been deemed competent and has met the entrustment scales for unsupervised practice, they're still going to micromanage. They still want to be part of every decision because it's their name on the chart. And of course, they have that right. But if you're one of those faculty members, I encourage you to embrace it and just be honest with your trainees and say, you know, I know that you're competent to do this, and maybe they're even graduating, you know, and going to be and attending the next day. But for the day that you're supervising them, you're going to be involved a little bit more than some others might be. And so at the heart of entrustment is trust. And so we'll talk about trust a little bit. It's important to understand that trainees and supervisors might have different perceptions of competency as well as of trust. And so the trainee's understanding of their supervisor's trust can affect their perception of their patient care responsibilities. It can affect their opportunities for learning and their overall growth as physicians. Optimal trust is really associated with supervision that balances supervisor availability and resident independence. It allows for, is associated with tasks that afford participation in decision-making. And it's associated with trusting relationships with supervisors and a workplace that fosters appropriate autonomy and team inclusivity. So we can support optimal trust in learning with tailored guidance, confidence, and lessened vulnerability, and a sense of patient ownership and team belonging. And it's really important for supervisors to be aware of their trainees' interpretations of trust because it affects how they understand their patient care roles, perceive autonomy, and how they approach their own learning. So we'll go through some tips for implementing EPAs for the assessment and trust decisions. So for supervising clinicians, it's important to talk explicitly about trust with learners. And so the supervisors need to make clear to learners from the outset that the concept of trust influences both their participation in the workplace and their assessments of their performance. And often learners tend not to recognize the role of trust and only focus on the competencies, so attaining the knowledge and the skills that they need for patient care or to accomplish a specific EPA. But it's important for supervisors to set expectations and ensure that learners understand that they're assessed on all of the key qualities that enable trust. And so competence, which is the knowledge or the skill to perform a specific EPA, really needs to be complemented by integrity, so truthfulness and benevolence, as well as reliability, so being conscientious and having predictable behavior, and humility. So a trainee being able to recognize their own limitations and willingness to ask for help as needed really are essential to be able to develop competence. And demonstrating these qualities can inform decisions about the levels of supervision and entrustment and the professional responsibilities granted to learners. And this happens on a day-to-day basis for workplace participation and also when doing summative assessments. And trust is a two-way street. And so learners really should understand that trust in their supervising clinicians is also an expectation. Supervising clinicians should also use the elaborated EPA descriptions to inform learners and guide teaching. So as I mentioned before, there are 3 EPAs for pediatric critical care, but again, those descriptions really are 1 to 2 pages, if not longer. And so you can use those descriptions to shape and focus the experiences and practice opportunities with the goal of preparing learners for those entrustment decisions. Some people might use the EPA descriptions and definitions as endpoints for summative entrustment decisions and transfer of responsibility, but that's really a narrow view and it misses an important opportunity. You can use the EPA as a roadmap or even a mini curriculum of how to get to entrustment. And, we all work in busy clinical environments. And so it may not always be clear what the expectations, opportunities, and useful activities are. And so we can use these EPAs to specify learning objectives and identify really what exactly a learner must master in order to achieve competence. And so you can look at the EPAs to look at what is the required knowledge, the skills, attitudes to guide these experiences and opportunities. And sharing those descriptions with learners can empower them to direct their own study and to look for those experiences that they need. And so you can create this mini curriculum by those EPA descriptions and focus the learning activities. So here we have an example of an EPA that can be used as a mini curriculum. Here, the EPA is the routine checkup of the stable adult patient. Obviously, this doesn't necessarily apply to pediatric critical care, but you can see here that it really identifies the specifications and limitations. So what exactly needs to be accomplished? It identifies the relevant competency domains. It identifies the required experience, knowledge, skills, attitude, and behavior that must be demonstrated before entrustment can be granted. And it also identifies the sources of information for that assessment. And it provides a timeline as well. So some more tips for supervising clinicians would be to provide learners with opportunities to practice higher levels of responsibility ad hoc. And so learners should and need to have opportunities to gain experience performing a professional activity at increasingly higher levels of responsibility before they can be fully entrusted with it. And so you might ask a learner to practice a certain task in a controlled learning situation with a higher level of autonomy, so giving them ad hoc entrustment without the promise or certification that they might, or from that point on, always work at that same higher level of autonomy as a summative entrustment. And this is an important distinction because daily or ad hoc entrustment decisions really depend on the circumstances, and those might change day to day. And so as supervisors, we have to judge every situation separately for the patient risks that are involved and the safety for the learner to practice in that specific situation. And again, making these ad hoc decisions really is based on presumptive or initial trust. So for example, if you're supervising a trainee who's at an entrustment level of direct supervision for an activity, you can give them opportunities to practice being responsible to perform that activity under indirect supervision while still giving them support in the training environment. And so having multiple experiences with these ad hoc decisions showing that the learner can be entrusted with a specific professional activity under indirect supervision can then lead to the eventual summative entrustment decision for indirect supervision. We can also use EPAs to identify and create opportunities for assessment and focused feedback. So supervising clinicians should use the EPAs to anchor and focus feedback. And so it can really provide grounds for credible and effective feedback sessions because you have clear performance expectations, and this is informed by direct observations that are embedded in clinical practice. And so you have feedback that really should enable your supervisors and learners to engage in a dialogue about the learner's progress toward achieving a desired level of entrustment. And you can adjust their learning goals and practice opportunities using this dialogue. Supervising clinicians can also use case-based discussions to support entrustment decisions. And so these can provide additional insights into learner abilities. So using this framework, you're not focusing on past performance, but rather on future performance. And so trust in the learner's ability to handle future patients and situations that might pose new challenges. We all know it's not possible to observe learners in every imaginable situation, and so we might use adjunctive methods to tell how they would perform in situations that they haven't yet encountered. And so case-based discussions are a nice way to do this. You can have a pre-formulated scenario where you can talk about a rare or a risky situation. And so the 4 steps to perform case-based discussions can easily be integrated into your daily workflow. So after a professional activity, either directly observed or not, you can ask the learner to explain what's been done, to exhibit their background knowledge, describe risks or complications, and to explain how they would have acted if the situation or the patient had been different for any reason, whether it's a different culture or medical history or a different finding, or if there's a different abnormality. And valid learner reactions can also include an awareness of when to ask for help. It's also important for supervising clinicians to listen to and try to understand their gut feelings about learners. Sometimes supervisors might feel uneasy granting more autonomy, even if all available data shows that the learner's ability is satisfactory. And really, we shouldn't deny those gut feelings, but listen to them because they might be a voice to our unconscious processing of previous experiences with those learners. And we know that not everything can be easily measured or expressed in numbers. And so we should reflect on these feelings when it comes to the question of whether or not you can trust a learner to execute a critical task without direct or indirect supervision. And if your gut feeling says no, you really need to ask yourself why and examine the information you have about the learner, not just about their competence, but it may also be related to their integrity, reliability, or their humility. And so tips for curriculum leaders. Of course, we need to enable and facilitate the development of trust. And so we need to aim for more consistent supervisor and learner pairings. So having longer periods of working together or more longitudinal clinical placements are very helpful. Because supervisors really need to have sufficient opportunities to develop trust in the learner. So the longer the relationship is between the supervisor and the learner, the better the supervisor can estimate their capabilities, their limitations, and the more valid those entrustment decisions will be. For curriculum leaders, they should apply trust decisions to all levels of graduated supervision scales. And so trust decisions should be made at each step of the learner's developmental trajectory and not just at the end. And so a learner progresses through many steps on the way to achieving full entrustment. And so they can and really should be assessed and given increasing autonomy at each of these pre-entrustable steps. And so that aligns with and formalizes the gradual decrease of supervision practiced by their supervisors. Curriculum leaders should use all available sources of information in the workplace to ground their entrustment decisions. And so all data should really be used to assess learner performance, and we can use other sources besides direct observations. And so those other sources might be their entries in the health record, their discharge letters, post-operative reports, if that's applicable to your specialty, activity logs, self-remediation plans, patient satisfaction, and also tests, so their training, in-training exams and boards. And so using all of these different sources really gives a more complete picture for the learner, and it can also give a more complete picture for the clinical competency committees as well. Curriculum leaders should also encourage learner ownership and engagement in the assessment process. So we know that typically learners can feel that feedback is sort of just given to them rather than participating in bi-directional feedback. And so they can use the EPA focus on increasing autonomy as a way to motivate learners to ask for observation and feedback on areas that they need to be assessed on. And so they can direct their supervisor's attention to their individual growth targets and ensure that they're being assessed adequately on all of the EPAs. And learners can reflect and self-assess their levels of entrustability to provide insights into their development as well as their limitations. And all of this can be used as points for feedback sessions. In addition, learner ownership and engagement can also help institutions reflect on the learning environment. So whether or not that learning environment provides sufficient opportunities for them to achieve their desired developmental goals and levels of supervision. Curriculum leaders should also use technology to facilitate the documentation of progress. And so using electronic portfolios, for example, can help track the EPA-based workplace assessments. And continuously documenting the learner's professional development and progression does allow for early signals of strength as well as weaknesses. So you can identify earlier what really needs to be worked on. And supervisors and competency committees can use all of this information to guide entrustment decision-making. And again, learners can be empowered having this continuous documentation so that they can practice self-regulated learning and monitor their own progress in relation to their prior performance, the performance of their peers, and competency-based performance expectations. And so summative entrustment decisions can be placed in the e-portfolio as well. And so the learner knows exactly what EPAs they can be trusted to perform and at what supervision level. Curriculum leaders can also use aggregate data as measures for program evaluation. And so you can assess them at the programmatic level and help with evaluation and improvement of the program's curriculum. And again, this can help identify gaps in the curriculum. So where do we go from here? So it's important to have stakeholder engagement and leadership, as well as educational and technological support, and faculty and resident development. So as far as stakeholder engagement and leadership, we really need strong leadership for competency-based medical education because this really requires all leaders and programs to engage in a community of shared learning and leadership. And they need to appropriately allocate financial support, time, and educational resources to improve engagement and participation from faculty and trainees. It's really essential to have trainee engagement and feedback as well. And so having trainee subcommittees can help provide a forum for trainee advocacy and discussion. And again, it's essential to have continuous quality improvement in programs. We also need educational and technological support. And so these are really necessary for the appropriate curriculum delivery, assessment, and evaluation. And for example, we can use simulation for those EPAs that are less frequent because it can create new training opportunities that might not otherwise exist. And I think one of the most important ways that we can foster competence in our trainees is really to develop our faculty. And so as we all know, one of the most important elements in any training program is the faculty, because the faculty have the responsibility to provide high quality patient care and teach that level of care to trainees. So simply being a competent clinician is really not enough. Faculty members need to be competent to teach and provide graded supervision and have the interest and skills to do that education. So this includes teaching at the patient's bedside, providing appropriate feedback, and the ability to assess how trainees are performing. And unfortunately, these skills are not innate, and they're really not taught during routine medical education. And so they must be learned. Ways that we can learn this are informally from more experienced faculty members, or more formally in workshops or through other types of faculty development activities. So creating an educational environment is more than just instructing fellows about what actions to take for a particular patient. You really need an environment that's geared towards trainee education that allows time for questions and discussion about patients and the underlying reasons for evidence-based medical decision-making. And so you need to have discussions about, again, the evidence-based references, the pathophysiology, rationale, and you don't need to do this necessarily for every single decision, but you really need to have enough of this conversation to maintain an environment of constant learning. So when we think about faculty and resident or fellow development, we define this as any planned activity that's designed to improve an individual's knowledge, skills, and attitude in areas related to the roles and responsibility of that faculty member or trainee. Barriers to competency-based medical education, of course, include a lack of faculty knowledge and skills in order to shift to competency-based medical education, a lack of technological expertise to deliver the curriculum, and a lack of time and ability to provide proper assessments. There was a recent study in 2020 that was done by a group of educators in PICU called the EPIC Investigators that looked at expanding faculty development of teaching skills and did a national needs assessment of pediatric critical care medicine faculty. And so they surveyed 545 pediatric critical care faculty in 64 PICUs across the country. And all of these programs had fellowship programs. And so they found that the most frequently cited factors that motivated engagement in faculty development was having education as part of the regularly attended conferences, having resources readily available, and that their participation in faculty development was promoted by their supervisor. And in those that were surveyed, the preferred learning modalities were having brief discussions with colleagues, a 10-minute video, and again, regular conference series. And this study really, again, highlighted the fact that faculty development is essential, and supporting the faculty is really paramount to supporting trainees in the pursuit of competency-based medical education. Any questions?
Kim, thank you so much for that comprehensive look at how you fashioned your, and I guess, pretty standardized way of training and evaluating your residents. I have a couple of questions. The first one is, I'm sure you're aware of the JAMA open publication by Dr. Michael Lightman and his group, David Muller and these people. That's for GME education. You're aware of that, yeah? Mm-hmm. So how do you seek feedback? Is it anonymized? What are the power dynamics? And what are some of the pathways to resolve some of these issues that are brought up?
Seeking feedback for the program, or?
Yeah, from the trainees in the program.
So there are a number of ways that trainees can provide feedback. Of course, if they're comfortable, they can always go to their program director or program leadership. But there's also intermittent surveys of trainees. So ACGME sends out surveys every year that we that are anonymous and that we have results for. And then also through Mount Sinai, they send out surveys as well for trainees that we eventually get results for, and again, are anonymous. So there really is, especially here at Mount Sinai, continuous and constant reassessment and improvement. So I think that, we're lucky that we have those opportunities to incorporate the feedback.
Okay, thank you for that. Obviously, this discussion, especially regarding feedback and how to act on it and proceed on it, can be, I'm sure, at the PD level, is a subject of day-long seminars and so on.
Oh,
The
yeah,
question,
definitely.
how does one teach intangible skills? One of the very important intangible skills that you talked about, but not too many people pay attention to, is one of humility, because humility is not just humility. Humility engenders so many different qualities that arise out of it, feeling of selflessness, caring for others, and so on. And in today's atmosphere, at least, I'm sure you've been reading about some of our leaders, very lauded leaders who people are re-examining their legacy. For instance, Jack Welch and so on, got there not exactly by being humble. How does one model humility?
I think, just as you said, modeling it, I think, is the best way to teach it. I think, again, as you said, it's one of those soft skills that is very hard to teach. It's not like we can have a class and say, this is how you can be humble. But I think sort of as faculty members showing humility, especially when we're supervising trainees, let's say if there's something that you don't know the answer to, or you don't know the best course of action, to be honest and open with trainees. I think that's the best way to show that. And hopefully, having experienced it and witnessed it, that they'll also follow that model.
Excellent, thank you. Does anyone else have any questions? Is Dr. Norma Brown on this call? I think you've done a very comprehensive job, and I thank you for your time and efforts.
Thank you so much.
Good luck. Thank you, Dr.